Good morning, and thank you for joining us for another Ministry of Health virtual media conference on the national COVID-19 response. Our panelists today are Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, Dr. Anthony Parkinson, Director of Health, Northwest Regional Health Authority, and Nurse Grace Sukchan, Manager, Expanded Program on Immunization Unit, Ministry of Health. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health and your moderator for today's virtual media conference. Dr. Hines will begin with the latest clinical, epidemiological updates, as well as some information on the primary dose of COVID-19, additional primary dose of the COVID-19 vaccine. Dr. Hines, good morning.
Good morning, Mr. Alexander, and thank you. Good morning to my colleagues, Dr. Parkinson and Ms. Sukchand. Good morning to members of the media, members of the viewing and listening public. We'll begin with the clinical update, if we can have the first slide. And this is data as at November 7th at 4 p.m. As at that date and time, we would have tested 406,263 individuals at both public and private facilities, and we would have received a cumulative total of 59,304 total positive cases. Of those, 52,010 have already recovered, and there are 5,522 total active positive cases, which are distributed as follows. 368 individuals are currently hospitalized, while 4,804 persons are in home self-isolation, and there are 21 individuals in step-down facilities. The additional number that would bring us up to that 59,304 total would be the new positive cases diagnosed, confirmed rather, over the past 24 hours, and those would be from samples that were collected in the 48 hours prior to that. We've also had 1,772 COVID-19 fatalities, and we extend our condolences to members of those bereaved families. With respect to vaccination, at this time, the total persons who have received one dose of a two-dose regimen stands at 627,208 individuals, whereas those who have received either the second dose of the two-dose regimen or one dose of a one-dose regimen combined brings us to 615,701 individuals considered fully vaccinated at this time. If we move into the next slide, we'll go directly to the epidemic curve, and we see that, as we have been noting over the past year and change, the gray bars over to the left represent the numbers for July through December of 2020. The colored bars begin with January, move all the way through to the current month on the right-hand side, which is November, which is the dark green color. We also look at the dotted line that passes through that graph. That dotted line represents what we call the 7-day rolling average. And what we do see for the month of October, which was bright green, into November, is that that dotted line has an upward slant, an upward gradient. So there has been a steady increase in the rolling average, the 7-day rolling average, throughout the month of October into November. If we move to the next slide, we look at what that looks like aggregated at a weekly level. And what we do see is for the month of October, those bright green bars get progressively higher. The first week in November followed suit, so we've been seeing progressive increases. And if we look at the table over on the left-hand side, we'd see that week on week we've seen increases between 10%, 10.7, 10.1. When there were increases, some weeks remained more or less the same, and you had a 0.7% increase, but there have been no decreases. So that increasing trend has now been seen to have maintained itself for the past few weeks. So this is a trend of concern. And if we look at that salmon section at the background, we also note that what we've been referring to is the positivity, percentage positivity, meaning number of positive COVID-19 cases out of the number of samples that we've tested for COVID-19, that proportion or that percentage has shown a bit of an increase, where it hovered between 25 and 30% previously. It's been above 30% between last week and this week. This week is still new, data is still new, but this week so far we are approaching 40% in terms of percentage positivity of the samples tested thus far. If we move to the next slide, where we see the same data now aggregated at the monthly time scale, we see a similar pattern. The bright green, representing October, ended with a total that was a bit higher than the July, August, and September totals. We are already at maybe 1/3 of the total for October, really just in the first week of November. So we're seeing that we're collecting or accruing cases at a faster rate. And we also see that the percentage positivity is showing that upward trend, which is also a cause for concern. So we're looking at increasing numbers of cases in the more recent weeks, and the background positivity also increasing, indicating that we do have to be careful, and that our need for adhering to the public health guidelines and optimizing the number of people vaccinated continues to be of paramount importance. Next slide. If we look at the demographic, as we call it, the age and sex distribution of the cases seen so far, we note that while that 25 to 49 age group continues to hold the majority of the cases, the under 25 does show a little bit of an increase. The over 60 basically holds steady, the over 50 as well. We are looking at the balance of males to females, and we do see that, yes, there's still that 50-50 just about balance of males to females among the positive cases at this point in time. Next slide. Among the fatalities, we note the pattern that has established itself, where 2/3 of the fatalities in the over 60 age group, and just about 57% of them are male. Added to this, we do note that among the risk factors for having an adverse outcome, you do have presence of any pre-existing condition, any what we call comorbid condition. And in addition to that, we do note that the fatalities have been largely among the unvaccinated population since vaccination became available. Moving to the next slide, looking at the geographic distribution, we see that the patterns remain largely the same, focusing on communities with higher populations, greater numbers of individuals and populations that are larger. And if we move to the next slide, we will note that when we compare the previous week with the current, so we're looking at the completed weeks 42 and 43, we see that many of the counties are seeing now an increase, whether it is a mild increase or a more moderate one. We see that several of the counties show an increase, while Victoria happened to show us a small decrease. And the overall upward trend is reflected by the fact that there are actually more counties and larger counties that are showing an increase from one epidemiologic week to the next, looking at these figures. Moving to the next slide, we do see that if we look at the data from week 25 through to the present time, there are several counties that are seeing that sort of upward trend, progressively taller bars, moving from left to right. On the right-hand side of the bar, on the right-hand side of each group, we're seeing where some counties have been seeing 3 or 4 weeks now of increasing bars going a little higher each week. And that, again, is the sort of upward trend that we've been describing that is now being disaggregated at the county level. So moving to the next bit of the presentation, as we said, this upward trend is really best battled by ensuring that everyone is optimally vaccinated. And one of the new recommendations, an interim guideline released by WHO around that third primary dose of vaccination, is something that we've gone over on Saturday, but it bears repetition, so we will go through that slide deck again. So if we move directly into that slide deck, we will just repeat for the benefit of those who may have missed Saturday, the new guidelines on an additional primary dose of a COVID-19 vaccine. So we're saying that this additional primary dosing is given to enhance the immune response of certain individuals in particular groups, and those groups include the elderly and those who have immune-compromising conditions. And this is now a part of the WHO primary series for these groups, as opposed to a booster. It is an additional primary vaccine to strengthen that initial response to the vaccination, that initial immune response, and add protection for these groups. So the interim recommendation as it relates to Sinopharm is that an additional third vaccine is given to individuals 60 years and over. So for Sinopharm, that 60 plus age group will be targeted for an additional third vaccine, and those individuals will be called from the database that we have. We'll reach out to individuals to call and schedule a visit. So we don't want everyone to descend on the health facilities at once, but those individuals will be called out to receive their vaccinations at the various relevant centers. And this dose is to be administered between 3 and 6 months after the second dose of your Sinopharm vaccine. With respect to interim recommendation number 2, relating to immunocompromised individuals, an additional vaccine dose is to be administered to moderately to severely immunocompromised persons. What do we mean by that? Next slide. If we look at the groups that they've targeted and highlighted as immunocompromised, they include those with active cancers and active cancer treatment, transplant recipients, those who have immune deficiency, HIV, and those on immunosuppressive therapy. And Dr. Parkinson will go into the details of that after this presentation. Going to the next slide, we note that for the AstraZeneca, Sinopharm, Pfizer, and Johnson & Johnson, an additional third dose for these immunocompromised individuals would be recommended to be taken 1 to 3 months after the second dose. And again, because the majority of these individuals in the categories listed are within the public sector, those individuals will be targeted through the public sector clinics. Those who are not in the public sector will bring a referral, as you'll see a little later. And once they get the referral, either from their specialist or from their primary physician, they will also be accommodated for that additional dose under the rubric of being immunocompromised. Next slide. So standard practice. The additional dose, whether for persons 60 years and over or for the immunocompromised, is expected to be the same vaccine product used in the first instance. So if you got Sinopharm before, your additional dose will be Sinopharm, and so on. Moving to the next. The referral letter that we spoke about is really if you are in the immunocompromised group, not in the public clinics, and require your private doctor to provide some evidence to the health system that you are immunocompromised and require an additional dose. Those letters will be taken into consideration, and the additional dosing will be scheduled as needed. Now, as we said before, these groups, because they're in the public health or the public sector, those immunocompromised groups in the listing that we gave before will generally be targeted within their clinics, so they don't have to bring a referral if they already belong to clinics in the public sector. Next slide. All right, so that basically brings us to the summary of what we had what we had spoken about on Saturday. We are reiterating that now, and beyond that, for those who may fall into these groups and have not yet been vaccinated, we continue to encourage all individuals, especially those with additional risk, being in the older age groups, being immunocompromised, having pre-existing conditions. If you haven't been vaccinated yet, vaccines are available, and we would like to encourage all persons to access the vaccines and make sure that you reduce your own personal risk of serious illness and or possible fatality with COVID-19 infection. That summarizes the clinical, epidemiological, and vaccination update. I'm going to turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines. Now we welcome back Dr. Parkinson, who will provide us with additional information on the categories of immunocompromised persons who will be eligible for an additional primary dose of the approved COVID-19 vaccine. Dr. Parkinson, good morning and welcome back.
Good morning, everyone. Thank you, Al. Good morning, everyone. I think I'm back online now. Thank you so much again for inviting me to this conference. I want to go straight off into immunocompromised. Now, right now, COVID walks amongst us. Let's get that fact straight. We couldn't get rid of it. No country could get rid of COVID. It's here to stay. The Delta, like Delta Force, is amongst us right now. So we are all going to be exposed to it. However, what we want to focus on those people who are most vulnerable. Now, we talked about people who have comorbidities, hypertension, obesity, kidney disease, heart failure, all these different people. We talked about that, but there is a particular group of people that we have to focus on, and these people are the immunocompromised. Now, when you get your vaccine is supposed to work along with your immune system, your ability to fight back. These vaccines are supposed to make that immune system even stronger, give you a fighting chance to fight against this virus. However, some people have a weak immune system. Even though you get the vaccine, it's like a little push. Like you have a dead battery, you give it a little jump start, but yet it will die again because it's weak. So what can we do for people like this? You give them the vaccine gives you a little help, but the immunity wears off very quickly or doesn't reach a good level in the first place. So now you are still vulnerable, very vulnerable to the COVID. With or without vaccine, you are vulnerable to the COVID. So there are different types of immunodeficiencies. Some people are born that way with some weird and wonderful diseases. So I say weird and wonderful because it's not necessarily my specialty about primary immunodeficiencies. Some things like chronic granulomatous diseases where the cells that eat bacteria don't work too good. And what happens? They can't fight against fungus or bacteria, so you're defenseless. Some people have low white cell counts as such. They're born that way. So those are defenses against these aliens, and they cannot fight it. So those are primary immune deficiency. But there are people also that get it because of illnesses like HIV. HIV licks up your immune system. You also have people with chronic kidney disease. I want to focus a little bit on them today. Chronic kidney disease cuts down your immunity fairly well for quite a lot. In fact, in Trinidad, one of my colleagues has indicated to me up to almost close to 30% of the chronic kidney disease people who get COVID succumb to it, unfortunately. Up to almost close to 30%, 29% of them apparently in Trinidad succumb to this COVID, even though some of them may be vaccinated. We don't have all the data on that yet, but they succumb to it. So we want to look at people, especially chronic kidney disease people, who are immunocompromised because of their disease state. Also, there are people who are cancer people, whether it be blood cancers or solid tumor cancers, so cervical cancers, colon cancers, prostate cancers, whatever. When you take drugs to fight the cancer, these drugs compromise, weaken your immune system. So we want to get vaccines for people like this to be able to boost them up. That's why we're asking for doctors to give you a letter, because we want to time it right. Because sometimes you go through a course of chemotherapy that will drop your white cell count down, will drop your immunity way down to the bottom. We can't give you the vaccine at that exact point in time. It makes no sense. But the doctors will tell us, okay, we've given you a course, you are recovering your immunity. Good, let's give you a vaccine at that point in time so your immunity can rise up and be better able to fight this disease. So anybody with any immunological problem, any inability to fight the disease, we want to give the vaccine to give you a fighting chance. Now, some people have gotten the vaccine already. WHO is focusing on these very susceptible people who have compromised immunity. This vaccine is to give you that fighting chance, and we hope you can get it. If you could put up the slide again, sorry. It talks about the different types of immune disease. I talked about HIV, chronic kidney disease. I talked about the neutropenias, chemotherapy, right? People who got transplant recipients. We have a nice active kidney transplant system in this country, and these people who get these transplants, because it's somebody else's kidney, you have to get these drugs to quiet down your immune system, else your immune system is going to lick up that kidney, that donated kidney. So these same drugs that quiet down your immune system so it doesn't destroy the kidney, unfortunately it also compromises your ability to fight viruses. So people who had transplants also will need to get an extra dose of the vaccine at the right time, at the right place. Now, I keep saying this, an additional dose. Mind you, you should have gotten your first doses already. You shouldn't be waiting now to get a third dose as such. You should have gotten your doses already. If you haven't, please, I implore you, get those doses as early as possible. You're the most susceptible persons on this country right now. Those who are immunocompromised. Immunodeficiency, as you see here, severe primary immunodeficiencies. I talked about the funny granular matter disease. People who are on chronic dialysis, who are on dialysis right now, there are only 2 areas in this country where people can get dialysis who are COVID positive. That's in the Couva Hospital and in the Rima Hospital. And right now, those dialysis chairs are full. We could barely take any more people. So, please, COVID positive, kidney dialysis, we need to be protected even more. HIV, of course, those of you who have HIV and are going to talk about what it means by a CD4 count of less than 200. You have HIV, you know what that means. If your CD4 count is less than 200, that means your ability to fight infections is compromised severely. You already have severe compromisation of your ability to fight. So if your CD4 count is less than 200, please make yourself available to get your additional vaccine right now. Also, if you have any other opportunistic infection, meaning that another infection has come about because of your HIV infection, that's another reason why you should go and make sure you get your additional dose. We have the immunosuppressors we talked about. Not only cancers, but some things like rheumatoid arthritis and other gut problems where you need to have these drugs that suppress the immune system because, you would have heard of people who have autoimmune disease. That's where your immune system destroys itself. It's destroying organs in your body, like your joints and your gut, etc. When you're on these drugs, it also depresses your ability to fight. So what we are advising you to do as well, those you guys who have these diseases, please see your doctors so that they could tell us when we could give the best time for us to give you these vaccines. Some of you on pulse therapy, meaning that you get a dose now and then it wears off for a while. When it wears off a bit, then we're going to give you the vaccine. So, in summary, for those who are immunocompromised, please come and get your 3rd dose. All right? The Ministry of Health has put as best they can to make an opportunity for you to get it. It's available. Don't lose this opportunity. Those of you who have chronic kidney diseases, please, I want you, for those of you who are living in a household, one of your members at home has chronic kidney disease, increase the protection for them. You yourself get the vaccine. You yourself guard up your immune system because you don't want to spread it to these people as well. They're so compromised. You don't want to give them another chance to break this armor around them. So you yourself, please get your vaccines. Be updated with these vaccines. I'm not going to get on my hands and knees to beg people to come and get the vaccine for those who are immunocompromised, but we're focusing on those who are immunocompromised today. Please come and get your vaccine. Give yourself an additional fighting chance. My doctors are talking about patients who they come to their beds and they're no longer breathing. COVID takes your breath away, sometimes very quietly without a whimper. Patient just dies. Our doctors are under stress. Please don't give them even more stress. Don't become another victim. Get your vaccine as early as possible. Thank you.
And thank you, Dr. Parkinson, for a very powerful presentation. I really hope that information gets through to those persons who need it. Now, with the focus on COVID-19 virus and the vaccines, we should not forget that we are still in the flu season, and there are vaccines available free to the public at your nearest health center. Here to tell us more on the new flu vaccine is Nurse Grace Suchan. Good morning.
Good morning, and thank you, Mr. Alexander. Good morning to... You're hearing me?
Yes.
Yeah.
Okay. Good morning, Mr. Alexander. Thank you. Good morning to Dr. Hines, Dr. Parkinson, members of the media, and you, the viewing and listening public. Thank you all once again for having me here. And yes, as Mr. Alexander mentioned, the flu season is once more upon us here again. So can we go to the first slide, please? Next slide, please. So basically, it's an overview of influenza. It is a viral disease that affects millions of people worldwide and kills approximately 500,000 people annually. The high burden of disease occurs primarily in children and those persons 60 years of age and older. The flu season normally starts around October and goes on till May of the following year. Next slide, please. Thank you. So, what are the symptoms of influenza, flu, and COVID-19? And I want you to look at the side carefully, and you would see that there is some similarities. When you look at COVID-19 symptoms and influenza symptoms, you see some similarity with respect to fever, fatigue, sore throat, muscle pains or ache, headaches, and the same thing is reflected in the symptoms for influenza. That being said, we also have to remember that the common cold is also circulating around this time. And while the common cold symptoms are more mild, they share similarities, and therefore we need to be very mindful of that. Cold symptoms are usually milder than symptoms of flu. So with cold symptoms, the onset is gradual, whereas with flu, it is more abrupt. You have a slight ache in flu, but usually in cold, but in flu you usually have the body aches. Chills are uncommon in cold, but fairly common with flu. Fatigue and weakness is very much usual in flu, but common in cold. Chest discomfort, cough is mild to moderate in cold. And of course, in flu, sometimes you may get stuffy nose or sore throat, but it is very common in cold. Headaches is rare in cold, but in influenza, it is common. Basically, what we are saying, if you have any of these symptoms and you are unsure of those symptoms, then you should seek medical attention. So people with colds are more likely to have basically runny or stuffy nose, and these symptoms generally do not result in serious health problems, unlike the influenza. Next slide, please. So what are the trends in influenza uptake? What we have noticed? We have noticed that our chronic disease population, or the population that normally comes out and accesses the vaccines at the health facilities, but there are other categories of or target group persons that we are looking at. And one of the key objectives of our influenza campaign is to improve coverage among all high-risk groups in the population. Next slide, please. So why vaccinate against influenza? In 2020, we saw high levels of COVID-19 infections. And of course, we had strict public health and social interventions, also referred to as non-pharmacological interventions. So we had little or no flu circulating. In the second half of 2021, as countries approach high levels of immunity to COVID-19 through vaccination and or infection, local and international travels, of course, will inevitably increase. Sorry about that. Now, the increase in people movement is therefore likely to increase in risk of introduction and spread of influenza and other respiratory diseases from countries where these viruses are circulating. And we are seeing now that most countries are opening their borders, and therefore persons are traveling. And because of that, there's risk of flu virus circulating that's imported and then spread among us locally. Next slide, please. And who are our target population? Can we change the next slide? Right. So who is our target population for the flu season? Of course, children aged 6 months to 5 years, adults 65 years of age, persons suffering from our non-communicable diseases, pregnant women, persons with compromised immune system, persons with chronic respiratory illness, persons who are obese, overweight, our healthcare workers, very important category of staff right now, who are really our frontliners and facing the impact of COVID-19 with the population. Members of the National Security Force, Customs, and Immigration. So these are persons that we are looking at to receive the flu vaccines. Of course, we are offering it to the general public, but we would like to see members listed in this target group coming forward. Next slide, please. So where can persons access the influenza vaccines? Influenza vaccines are currently available at all 109 health centers throughout Trinidad and Tobago. We are also offering it at the mass vaccination sites and again at private physicians' office. So we do have some sentinel physicians who receive vaccines from us, and these persons do have the vaccines, and the general public can also, if they feel comfortable, go to their private doctors and have the influenza vaccines. So in conclusion, next slide please. Oh, I didn't see that slide. Okay, so when to take the influenza vaccine and the COVID-19 vaccines? Now, it was mentioned that the AstraZeneca, the Sinopharm, and Pfizer are 2 doses of vaccines, and of course the Johnson & Johnson are 1 dose. It's a 1-dose vaccines. So therefore, you can have your influenza vaccine either 2 weeks before you get your COVID-19 vaccine, or 2 weeks after you would have had your 2nd dose for the AstraZeneca, Sinopharm, or Pfizer, or 2 weeks after you had your 1 dose or 1 shot Johnson & Johnson vaccines. Please do not take 1 dose of your COVID vaccine and then go and get your influenza. You must wait 2 weeks after you complete your primary series before you take your influenza vaccines, or again 2 weeks before you start your primary series of the influenza vaccine. Next slide please. So in conclusion, COVID-19 and influenza viruses are similar in transmission, symptoms, and treatment. And as we enter the flu season, it will obviously be difficult to differentiate between these two. Vaccination, therefore, is the most effective way to prevent infection and severe outcomes caused by the influenza viruses. And please, we must maintain continued social distancing, wearing face masks, hand washing. This will help decrease the incidence of viruses, also referred to as our public health guidelines or non-pharmacological interventions. Thank you all very much. Mr. Alexander?
Thank you very much, Nurse Sukchan. So, ladies and gentlemen, you owe it to yourself. Please get the vaccine, not the flu. And now we move directly into our question and answer segment. I invite the media representatives to indicate your name and the media house that you represent before posing your questions. And in the interest of time, we ask for a maximum of 2 concise questions per media house. As usual, if time allows, we will facilitate additional questions. This morning, we begin with Power 102. Good morning.
Good morning, Sparkle McIntosh, Power 102 Digital. My question is for Dr. Hines. Dr. Hines, allow me to preface my question with a bit of information that our newsroom has been privy to, taking into consideration patient confidentiality, and out of respect for the family, I would try to refrain from giving particulars. An individual indicated to us that a relative was hospitalized at the Eric Williams Medical Sciences Complex for approximately 1 month. In addition to that, 1 month ago, that individual was discharged while awaiting critical medical treatment. That person subsequently passed away. My question is the Ministry of Health satisfied with the standard of care in the primary healthcare system, given the strain on that system as well as the parallel healthcare system amid the COVID-19 pandemic? Thank you.
Just one question.
Okay, so apparently there's just one question. With respect to the satisfaction in the Ministry of Health on the primary healthcare system in general, the implementation of that parallel healthcare system has managed to reduce strain on the institutions of the primary healthcare system and to allow them to continue to function. And while I do not have the information specifically on the case to which you're referring, the judgment on overall performance of that existing healthcare system would be a judgment that either the minister or the chief technical officer would make, and not someone at my level. So I would not venture to express satisfaction or dissatisfaction at this level. I would only venture to say that the ministry's implementation of the parallel healthcare system has been bearing fruit. and the functioning of the existing healthcare system continues to benefit from that.
Thank you very much, Dr. Hines. We move to AZP News for your questions.
Good morning, Priya Bihari, azbnews.com. My two questions are for Dr. Hines. Dr. Hines, I want to talk a little about herd immunity. The figure we initially heard was about 700,000. I think we have 615,000 people now who are fully vaccinated. So, but we still seem to have an increase in cases. Why is this if we are so close to herd immunity? And second question, there is another a number of cases in another school that has been reported. Is the ministry concerned that we should about having unvaccinated teachers and students in school? Thank you very much.
Okay, thank you for the two questions. I'm not sure where you got the figure of 700,000. I know that when we spoke initially about herd immunity threshold, we were looking at between 900,000 and 1 million individuals. And that was when we were still looking at herd immunity with respect to the variant that was slightly less transmissible, that variant being the Gamma variant, and before that, the R1 variant. Those variants were less likely to transmit themselves from one individual to another than the current variant, which is establishing itself as the new dominant strain, that being the Delta. So we continue to see increasing numbers because we now have a variant with an increased transmissibility in circulation. And the only real remedy for that is to help to decouple those increasing numbers from increasing hospitalizations and increasing deaths by having increasing levels of vaccination for your own protection. Each individual who is vaccinated has a greatly reduced risk of having serious illness and death, even if they do happen to contract the COVID-19 virus. So hopefully that answers and clarifies that question. With respect to the next question, the individual risks that each person takes with respect to whether they're vaccinated or not are, as we've always said, an individual choice. We know that the overall public health recommendation is that as many people be vaccinated as possible, and the extent to which we have largely vaccinated populations is the extent to which we will reduce the risk of transmission of illness in any population. So all we can do is really to continue to drive the message home that the vaccination of individuals helps both them, the individual themselves, and the overall reduction in risk of transmission in any setting where people gather. Hopefully that also addresses your second question.
Thanks a lot, Dr. Hines. We go to Guardian Media Limited for your two questions.
Hi, good morning, everyone. Kevin Feldman, Guardian Media. Dr. Hines, there's a study from the University of Oxford suggesting that people of South Asian ethnicity have a gene that makes them more susceptible to lung failure from COVID-19. We noted such occurring in our East Asian population locally, and can vaccines also protect against this lung collapse despite their genetic predisposition?
Okay, interesting question. Now, vaccination does what it can to improve your immune system's ability to respond to an infection, whether the infection is viral or otherwise. But the ability of your immune system to respond and the ability of your body in general to recover from illness also is affected by additional genetic factors. So there will be a play-off or trade-off between having particular genetics that are an additional risk for severe outcomes and having the vaccine on board. One of the things the vaccine will do is reduce your risk of getting infected in the first place. So the vaccine will still help to reduce the risks of those outcomes by reducing your risk of becoming infected in the first place. We don't have any information that would suggest that we're seeing the effect of that particular gene in our population. The data collection isn't really set up to make that sort of determination. But the bottom line is, once we're vaccinated, you reduce your risk of becoming infected in the first place, and therefore, whatever your genetics are, that reduced risk of infection is going to reduce your risk of an adverse outcome. So we again want to encourage all individuals to become vaccinated.
Thank you, Dr. Hines. TV6, good morning. We're ready for your questions. Good morning, TV6.
Good morning, Urvashi from TV6. Dr. Hines, I was just going to start off with a request. Well, actually, just a reminder on the data on excess deaths. I had in the past asked Dr. Parasram, and he said that in the future you would try to present that to us, excess deaths. My first question is, we were told in the past that 3% of the deaths due to COVID were in fully vaccinated persons. Dr. Hines, are you able to say which vaccine generally had been used, or could you disaggregate the vaccine which had been administered and the length of time post full vaccination that these persons would have died? My second question, as you mentioned, Dr. Hines, we have moved from a 30% positivity to now you said you're nearing 40%. And as it also relates to the increased number of cases and so on, can you give us an idea as to the pediatric population? Are you noticing increases there? And what type of increases are you noticing in terms of infections, hospitalizations, and possibly deaths? We haven't heard of any, but if you could give us that information, particularly as Delta, you mentioned, would affect children more. Thank you.
Okay, thanks for your two questions. With respect to reminder noted, that's something that we're actually working on alongside PAHO. And once we have that nicely summarized, that's information that we're very happy to share. With respect to your first question, the breakdown of different kinds of vaccine, I think is going to be skewed by the fact that of the vaccines that we have given, there is one predominant brand that has been given to the vast majority of those vaccinated. So it's not really, I think, useful to look at which brand we are seeing the numbers in, because you're going to be affected by the fact that the majority of the vaccines we've been given actually belong to one particular brand. Now, that being said, the time frames after which we're seeing these effects vary from very soon after, after the 2-week period, because we use that as the cutoff, to a couple months after, 1 or 2 months post the vaccination. But the more important thing is that in the individuals who did have a full vaccination regimen on board and then proceeded to succumb to the COVID-19 virus, one of the main factors that we saw, one of the recurring factors, was the fact that many of these people had quite severe comorbidities alongside their COVID-19 infection. So those with severe comorbidities and those who had comorbidities that would fall into the ones that we've discussed in some detail today, those that particularly compromise your immunity, those are the individuals that we did see predominating among those who would have passed on with COVID-19 in spite of having completed the vaccination regimen. With respect to the breakdown of the age groups in this current time frame, that's information that we're still gathering. That's information that we're still processing. I don't have the information on what is being seen at the level of admission in the institutions, but we are seeing a general upward trend in the age groups across the board, as we are seeing the overall increase in the numbers of cases. That increase is reflected across the board in all the various broken down age groups. And of course, with respect to the positivity, I want to point out that so far the positivity for the week that we're currently in is really based on 1 day of data. So let's look at how that sort of evens itself out before we determine whether we really jumped as high as 40. For the day that we've just seen, that's where the positivity level began. But let's look at how the rest of the week unfolds before we see if we've actually jumped that high, or whether that was basically an artifact of which samples happened to have been collected and tested at that point in time. So the increase that we're seeing across the board has been reflected in all the age groups, and the positivity is something that we're keeping an eye on. The excess death data is something that we'll come back to you with once we finish the work we're doing with PAHO. And the important thing about those who have actually had the COVID-19 vaccine and then passed on with COVID-19 is that many of these individuals did in fact have what we have just described as the immune compromising conditions that reduce your body's ability to respond to the virus.
Thank you very much, Dr. Hines. CL Communications, good morning.
Hi, good morning. I'm Natalie Singh, Caribbean Lifestyle Communications. I just have two minor questions. How do you plan to reach the immunocompromised patients, and do they have a special vaccination site to go to? Secondly,
sorry, who are the questions addressed to, please?
Oh, Dr. Hines.
Okay.
Sorry, my apologies. And then secondly, are you seeing an increase in cases now that the Diwali public holiday is over? I think the press conference had mentioned and warned the public about gathering for the public holiday. Thank you.
Okay, thank you. Not sure if you were tuned in when we went through these slides, but we did specifically mention that for those immunocompromised individuals, because they are generally receiving treatment within the public healthcare sector in their various clinics, they will be targeted via those clinics for their vaccination, for their additional primary dose of vaccination. And for those who are not in the public health clinics and who are receiving private treatment, those private physicians, whether it's your primary care physician or your private specialist, can provide a referral letter indicating the treatment and the suitability for your additional dose of vaccination, and that can be presented at the vaccine sites for the receipt of your additional primary dose of vaccine. Now, given that Diwali was, how many days ago? 2 or 3, not very many. Diwali was relatively recent. The impact of any sort of additional gathering or movement would not yet be seen in the data that we have. We also do have the previous experience of last year's Diwali, where the behavior of the population was such that we did not see a surge arising out of the potential activities that would have taken place around that time, and we have a certain level of confidence that those behaviors would have been continued into this year. We will look at the data and see if there are any changes, but we are actually quite hopeful that this wouldn't have had too much of an impact on the actual circulation of COVID-19 at this point in time. The data will tell.
The data will tell. We do have a follow-up question from TV6. Good morning again.
Morning. Thanks again. Dr. Hines, I'm seeing a lot of celebration in the medical fraternity and across the world over this new Pfizer pill. I was wondering, can that be currently imported under the current schedule of drugs? What will it take to have it here? And is the Ministry of Health, are you preparing to incorporate this as a treatment method for those afflicted with COVID? Thank you.
Okay, thanks for the additional question. As you are aware, before any of those considerations of utilization take place, what would need to happen is that this type of medication would need to receive the emergency use licensing or authorization. But once that is on track, once that is in train, conversations with the relevant companies will continue in terms of being able to access whatever is generally and globally recommended by the WHO as useful either preventative or therapeutic intervention. So we continue to do that, we continue to liaise and make preparations, and once the ability to do that is then supported by the WHO, EUL, EUA, then we'll move forward in that direction as authorization comes into play.
Thank you, Dr. Hines. Guardian Media Limited has a follow-up question. Good morning again.
Good morning again. Dr. Hines, I know you said that the Education Health team would submit reports to the ministry. So given that's another week, can you provide an update on the number of students, teachers, principals, and staff who were infected with COVID-19, whether they have been hospitalized, whether severe or critical, deaths, if any, within the school system since the resumption of school?
Okay, thanks for the question. What we said is that the Education Ministry is responsible for that data and that we provide whatever support is needed in terms of the response. And that when they do compile and share reports of that nature with us, then we'll be able to share that information. At this point, the best source for that information would still be the Education Ministry and the health team that operates under their purview. So I would advise you to direct the questions towards them.
Thank you very much, Dr. Hines. TTT, good morning. Your questions.
Good morning, everyone. Kimberly D'Souza, TTT News. Just a quick question from a member of the public. Apparently, the person went to one of the safe zone restaurants over the weekend and their vaccination card wasn't stamped. And so they were not allowed to get into the establishment. Do the cards need to be stamped? Because the member is saying that she got vaccinated at the, I think it's the racket center, in Tagarigua, and it wasn't stamped, but the owner of the establishment is saying that it should be stamped. So should your vaccination cards be stamped? Just a point of clarification. Thanks. And this is for Dr. Hines, by the way. Thank you.
Okay, thank you for that. I believe, yes, that the stamp is one of the markers of validity of these cards, so that the stamping of cards should actually be one of the factors that is taken into account in verifying whether a card is valid or not. I don't know if Ms. Sukhchand has anything to add to that in terms of validity. No? Okay, no. So that's the basic answer. They should be stamped. That's one of the ways that we know that it's an actual valid card.
Okay, thank you very much, Dr. Hines. We do have another follow-up question from TV6, so we go back to TV6.
Thanks again. Dr. Hines, as you know, cases have started to increase. We're now seeing an average of, 300 hovering just about there on a daily basis. Would you attest this to the movement of people? And what is the takeaway for the population as we prepare to go without a curfew by the end of this month? Thank you.
Okay, thank you. That's actually an excellent question, and it basically reinforces what we've been saying throughout. Increased movement is going to increase the risk of infected people coming into contact with uninfected individuals. And whether there is an enforced restriction of movement or not, what we want to have the population understand and abide by is the fact that once you reduce your risk of contact by reducing unnecessary movement, by adhering to the public health guidelines, by getting vaccinated, by keeping masks on both in enclosed areas and in vehicles, etc. These are the only things that are really going to help us to reduce that rapid increase that is possible if we have unfettered movement and lack of adherence to these restrictions. So the guidelines that have always been in place continue to be part of your protection, and whether it's enforced or not by law, the guidelines around movement and reducing unnecessary movement are scientifically the things that are going to help you to reduce your risk. So excellent question. With or without enforcement of reduced mobility, we do need to behave ourselves in a manner that will reduce our risk of contracting virus as we go about our daily business.
Thank you very much. CL Communications, follow-up question.
Hi, morning again. This question is for Nurse Sukhchand. A minor question. What is the flu vaccine uptake for October, and are people inquiring about it? Thanks.
Thank you very much for that question. Yes, we are actually getting a lot of calls, persons asking for the vaccines even before the vaccines arrive. The uptake on an average is a little over 2,000 a week, and we just started, so we are hoping that there's an increase in uptake at least by the end of this month.
Okay, thank you very much, Ms. Sukhchand. And we go back to Guardian Media Limited. Guardian Media Limited, for your follow-up question. Oh. Mr. Feldman? If you're muted, could you unmute? Okay. All right, so we can go across to, I think that's it for today. All right. Okay, so we'll come to the end of today's media conference. Remember that we all have an important role to play in protecting Trinidad and Tobago from COVID-19 and the flu. Keep making the responsible decisions to follow the health guidelines, and please take care of your mental health, for there is no health without mental health. And of course, let's vaccinate. Let's vaccinate TNT. Thank you.